My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation in Michigan, and this evening's Learn and Share conference call is entitled Epilepsy Treatment, Recent and Future Advances. And we're very pleased to have with us Dr. Ayman Haykal, who is an epileptologist at Spectrum Health in Grand Rapids. So, Dr. Haykal, can you just introduce yourself and give an overview of your clinical and research interests?
Yeah, thank you, Russ. Thanks for having me. I really appreciate this opportunity. So my name is Ayman Haykal. I'm a neurologist and epilepsy specialist, and I work at Spectrum Health Comprehensive Center, Epilepsy Center in Grand Rapids. Currently, I'm the director of the Epilepsy Monitoring Unit. My interests include surgical treatment of epilepsy, anti-epileptic medications, and also studying seizure semiology, and neuropsychiatric manifestations of epilepsy.
Okay, great. So, as the title suggests, we're going to talk about some of the more recent advances in epilepsy treatment, and then some of what's on the horizon and what we can expect in the future. So let's start by talking about some of the most recent additions to the growing list of anti-seizure medications. Can you give a brief summary of perampanel, which is Fycompa, eslicarbazepine acetate, which is the brand name is Aptium, and ezogabine, which is Potiga. If you can just talk a little bit about each of those and their mechanism of action, their uses, some of the possible side effects, and what some of your initial experiences are with their clinical use.
So maybe I can start in chronological order. Ezogabine, I think, was the first of these three to be approved by the FDA. I think this was almost 3 years ago now. So it's one of the anti-epileptic, anti-seizure medicines with a new mechanism of action, which is why many epileptologists were excited about it when it came out. So it is the first medication that targets the potassium channels. So opening these channels can result in a hyperpolarizing effect on neurons, basically decreases neuronal firing, leading to a seizure. In terms of side effects, it has some unique side effects compared to other anti-seizure medicines. One of them is blue discoloration of the skin, which is not known to happen with any other medication. We don't know this being a serious condition, although it can be bothering to patients. Another side effect that is probably also unique to that medicine is urinary retention. So that happens because of presence of potassium channels in the bladder as well. Some other worrisome side effects include possible prolongation of the QT interval on the EKG, which rarely can lead to arrhythmia. So caution is advised in anybody who has a history of heart disease, and we need to have a look at their EKG before starting treatment. And then it has also some of the other side effects that are, shared by other AEDs, by other anti-seizure medicines, including drowsiness, dizziness, fatigue. Recently, there was a warning about eye abnormalities caused by changes in pigmentation in the retina, and periodic eye exams are recommended because of that. One potential disadvantage is that it has a short half-life, so it needs to be taken 3 times daily. Perampanel, I think, was the one that was approved next. That was in 2012, but was marketed only recently. Also has a new mechanism of action. It works on a glutamate receptor called the AMPA receptor. So it also reduces excitation. Glutamate is known to be proconvulsant, so it promotes seizures in a way. So antagonist action against the glutamate theoretically reduces chances of seizures starting. Common side effects include dizziness, drowsiness, headache, which are not really unique side effects. But there is a warning about perampanel causing neuropsychiatric disturbances, so mood changes, and it might do this at higher frequency compared to other anti-seizure medicines. So caution is needed, especially when treating a patient with a history of a psychiatric disorder. One advantage is that it has a long half-life, so it can be dosed only once daily. And then the third medicine, the one that was approved very recently, is eslicarbazepine. And this is, in a way, chemically very related to carbamazepine and oxcarbazepine. It's a cousin of these two medicines that are widely used, as we all know. So it has a similar mechanism of action, which is basically on the sodium channel. There is some suggestion that it works on GABA currents too, and that it might have some effects on the slow sodium channels, which is the mechanism of action of lacosamide or Vimpat. So side effects are similar to other sodium channel blockers. They include drowsiness, dizziness, blurred vision, double vision. So they're not really different compared to carbamazepine and oxcarbazepine. In terms of therapeutic spectrum for these medicines, they were all approved for partial onset epilepsy as adjunct therapy. I've used ezogabine in a few patients with some success, and these were patients with drug-resistant epilepsy. I haven't used perampanel yet or eslicarbazepine in my practice, so I don't have much personal experience.
Okay. All right. So, what are some of the more promising anti-seizure medications in the pipeline, and do any of them have the potential to be groundbreaking therapies, or they are more likely just to be just an additional possible tool that you can add to your toolbox?
Well, in the pipeline, I think we only have additional tools. I mean, if we're talking about the short term, I think very soon we'll be seeing more medications for acute treatment of seizure clusters, maybe other methods to use benzodiazepines, especially using nasal sprays or nasal route. There's a lot of research already on using intranasal diazepam or midazolam. And there's also potential for having diazepam used intramuscularly as with an auto-injecting device, which can really offer patients with seizure clusters many other options. There is a medicine called brivaracetam, which is chemically a cousin of levetiracetam. So shares same mechanism of action in addition to some action against the sodium channel, and we might see that approved. We might be seeing an intravenous version of carbamazepine, which would be great in terms of acute treatment of partial onset seizures, maybe in a hospital setting. Stiripentol is a medicine that was shown to be effective in Dravet syndrome, one of the severe epilepsy starting in very early in life, and it currently has an orphan drug status. That hopefully it will become more available and get approval soon. I mean, I think in the short term these are the ones I can think of, but long term we might be seeing more groundbreaking treatments, some breakthroughs. Okay.
Can you talk briefly about the relative benefits of new medications that have completely new mechanisms of action versus the ones that are just variations of existing molecules or maybe extended release formulations?
So the ones that are variations of existing molecules or medications, basically extended release formulations, they basically offer more tolerability and less side effects because you have milder peaks of the medication level in your system, so theoretically less side effects. And they also offer the convenience of once daily dosing as opposed to twice or 3 times daily dosing. But they don't offer more efficacy in terms of seizure control. Medications with new mechanism of action, on the other hand, will allow doctors and neurologists to make logical combinations. So theoretically you can combine medications with different mechanisms of action and get better results in terms of seizure control. It does make sense theoretically, although we are yet to see some evidence of that from clinical trial. We don't have this evidence yet.
Right. And is there much of an incentive for pharmaceutical companies to invest in research to develop these novel therapies, and if not, is there anything that can be done to create that incentive?
I do think there is an incentive. The financial incentive is there, of course, and that's keeping the patent for a certain period of time. But we're also seeing that the market is becoming crowded, and we're getting more and more anti-epileptic medications. And if you look at the medications that were developed in the past few years, I don't think any of them was basically a breakthrough. As you said, we have more tools now, and medications that differ in terms of side effects and maybe more tolerable. But when you look at the numbers from clinical trials, they're not really much more efficacious. They do not provide much better seizure control compared to the ones we already have. So that makes it challenging a little bit for pharmaceutical companies in terms of the financial incentive, because there is basically more competition. So I think the best way to provide more incentive is through research. You need to do something different, I think, at this point, after having a lot of new medicines that are more or less equal in terms of efficacy. At this point, I think we need to focus on epileptogenesis and on providing treatments that might slow the progression of epilepsy or change the outlook of epilepsy long term. And that would be a great incentive for drug companies, because this is a market need, a huge market need that is still unmet. So research, I think, is very helpful. So how people and government can help in this regard is through research, through supporting research.
Sure. So how common is it for someone who has intractable epilepsy, who's tried virtually every medication, and I certainly work with a lot of people who are in that situation, and it seems very rare that a new medication comes along and that's the one that works for them. But do you have examples from your clinical practice, or how often does that actually happen, where someone who's tried everything and not gotten seizure control, and then a new medication comes along and that one for some reason just happens to work?
It happens rarely. It's certainly an exception. It's not something that we see commonly. So there's a study that is quite referenced in the epilepsy literature, in the epilepsy community. I actually mention it to patients when they've tried several medications, and we know that half of patients who are treated for new onset epilepsy, they respond to the first medicine. So if you try second medicine, if they continue to have seizures, and you try another medicine, a second one, then you increase this number by 13%. If you add the third medicine, your chances of achieving seizure freedom are less than 5%. So that doesn't mean, these are numbers, these are statistics. So when we say it's less than 5%, but it's not 0 too. So occasionally we do see that after trying several combination of medications, one medicine works for a certain patient, and they might be seizure-free for a while. So combining medications with different mechanisms of action is really promising. So it's great to have medications that are different. But again, we are yet to see a clinical trial looking at different combinations and proving this to be a fact, and we don't have this yet.
Okay. So can you talk briefly about why it's important to continue to invest in basic research? We've talked about investing in research for specific medications, but in terms of investing in basic research to better understand how seizures are generated and propagated, and how that can lead to new cellular and molecular targets for medications.
It's extremely important. There are a lot of different mechanisms involved in how seizures start and how they spread in brain tissue. We know that there is a big role that ion channels play in generation of seizures, like sodium channels, potassium channels, calcium channels, and most of the medications we have work on ion channels. But learning about other mechanisms can lead to different medications that might achieve better results, and can lead to actually rational design or designing a medication with a particular target in mind. Learning, for example, about the role of a neurotransmitter called GABA, GABA, was very important, and this neurotransmitter has anti-seizures, anti-convulsant action, and this inspired the discovery of vigabatrin, and was designed to target that GABA and make more GABA available for brain cells to exert inhibitory effects on seizures. Learning about the role of glutamate also inspired the discovery of Prevalence. Glutamate is thought to be pro-seizure, and then antagonizing the glutamate receptor might reduce seizures as well. So there are a lot of other targets that can be considered as well. You mentioned astrocytes, and these are brain cells that provide support and protections to neurons. So one can postulate that maybe medications that support the protective role of astrocytes can also reduce seizures.
Mm-hmm. And what about inflammation? I've heard, I haven't read much about it, but I've heard several people reference that as a potential new area to target for epilepsy.
Absolutely, and inflammation and also the immune pathways, and that carries the promise of maybe influencing the process of epileptogenesis, or the progression of epilepsy, or the long-term prognosis of epilepsy. So there is a lot of evidence showing that inflammatory pathways play a role in generation of seizures and in the epileptogenic process as well. And I think we will be seeing more research on that, and potentially more medications that can influence inflammatory pathways.
Okay. So that's actually a question I was going to ask later, but we might as well jump ahead to that. What epileptogenesis is really the process whereby the brain learns to have seizures, essentially. So and it can be a progressive process. And we mentioned the potential value of finding treatments to prevent or slow that process of epileptogenesis. Do we have anything yet in the way of possible treatments in the pipeline, or are we still there very much in the basic research phase?
We don't have anything yet. Epileptogenesis has been a hot topic, especially recently. there were some trials trying to see if the anti-epileptic medications we currently have may have an effect on epileptogenesis. So a medication that would influence epileptogenesis is one that would slow progression of epilepsy, or one that would result in improvement that outlasts the treatment period. So you give it for a certain period of time, but then the improvement lasts beyond that, which might mean it's preventing the progression or the process by which seizures are generated in the brain. And the studies that were done in the beginning, there were some trials on finding out whether empiric treatment with anti-seizure medicines can prevent development of epilepsy in patients with head trauma or stroke or a tumor, and the results were disappointing. But if we have a more target-driven approach that is based on basic science, then we potentially can have very promising results. So you mentioned inflammation, and there is a lot of research on the role of interleukin-1 beta and how this pathway is involved in epileptogenesis. There's a lot of research on immune pathways, specifically one called the mTOR pathway. That's the mammalian target of rapamycin, especially in disorders like tuberous sclerosis. And there are actually medications now being investigated for potential effects on that mTOR pathway, and hopefully this will offer a breakthrough in terms of epileptogenesis. So we don't have anything yet, but I think we're learning more about epileptogenesis on the cellular and molecular level. And I think hopefully this will lead to breakthroughs.
And that could, you mentioned it being used after some sort of trauma to the brain, like a stroke or injury to the brain, like a stroke or traumatic brain injury, or perhaps if someone was diagnosed with a condition like tuberous sclerosis, or could it even be used in cases where someone has a family history of epilepsy as a preventive measure?
It's too early to tell. That's a very good question. I don't think we're at a phase where we're realizing this goal yet. But ideally, yeah. I mean, if somebody is at risk, we know that they're at risk for developing epilepsy. Then can we, give them some sort of medication that makes this less likely to happen or prevents. We know that sometimes the process of epileptogenesis takes years. So sometimes patients have a brain insult, trauma or any type of brain or stroke, and then they don't have seizures until years afterwards. So is it possible to give them something to prevent that process that takes years and prevent seizures from emerging later in life? We don't know, but hopefully we'll get there. Okay.
So we've talked about medications. Can we now talk about some of the more recent advances in epilepsy surgery and neurostimulation? So just about some of the things that have come out recently, and then some of the things that may be on the horizon.
Now, one of the treatments approved very recently by the FDA, and probably most of the listeners know about it, is the responsive neurostimulation system. NeuroPace is the brand name. So this is a great option for patients who are not candidates for resective surgery, either because the seizure trigger is over eloquent cortex, which is a part of the brain where important function resides. For example, the trigger zone is over language area, or part of the brain involved in memory or vision, where we cannot do surgery because important function is at stake. It's also a good option for patients who have seizures coming from two separate trigger zones in the brain. For example, bilateral temporal, right and left. There are two trigger zones, and seizures start on the right and left independently. You cannot do surgery usually in this case, but responsive neurostimulation becomes an option. To find out whether a patient is a good candidate for that, you need to identify the trigger zone, localize it, and usually that's with invasive electrodes, implantation of electrodes on the surface or of the brain or deep in the brain. And then once you identify the trigger zone, then you implant electrodes that are to stay there indefinitely, and you connect them to a computer chip embedded underneath the skull. And then you can train that computer chip to basically detect the seizure discharges and deliver electric stimulation to try to abort them before they spread. And in the clinical trial, it was shown that the results were very positive and showed the reduction of seizure frequency by around 45%.
Were there? Do you remember what percentage actually became seizure-free?
I think the percentage that became seizure-free was no more than I think it's less than 10%, probably 7%. I'll have to double-check that number. But we have to clearly say that these treatments that are short of doing resection of the trigger zone are not usually curative treatments. Right. So usually we don't expect seizure freedom. We expect significant improvement in seizures, reduction in seizures, maybe a reduction in the severity and the frequency of seizures, but achieving complete seizure control is quite rare.
Okay. And what about
other treatments? Go ahead.
I was just going to move on to the next treatment. But you were doing that anyway. So go ahead.
Okay. Well, I was going to talk about stereotactic radiosurgery, and it's a technique that has been there for a while. It basically uses radiation to target the trigger zone where seizures start, while trying to avoid damage to the surrounding tissue. So that ionizing radiation can lesion the tissue, and it breaks chemical bonds and produces free radicals. Most commonly used source of radiation is what's called photon accelerators. The gamma knife is probably the most common. When it comes to epilepsy surgery, this method is usually considered for lesions such as mesial temporal sclerosis or hypothalamic hamartomas. The main complication there, potential complication there, is injuring the surrounding tissue. And then theoretically there is risk of developing secondary malignancies long term, after the procedure.
Because of the exposure to the radiation.
Correct. Also, one new technique that was approved by the FDA fairly recently is MRI-guided laser ablation. And again, you target the trigger zone, such as a hypothalamic hamartoma or a cortical dysplasia, or the tubers that we see in tuberous sclerosis, with an applicator that you insert during surgery using a stereotactic method, and then you apply the ablation, you apply the laser, and you use MRI to visualize thermal ablation and make sure you achieve the goal. The advantage of that treatment is that it's not very invasive, and compared to older methods of ablation, it's more precise, and then using MRI to make sure that you achieve the desired results is an additional advantage. Potential complications, I mean, like any surgery, you have to think about hemorrhage and infection.
Yeah. And the last two that you spoke of, the laser ablation surgery and the gamma knife surgery, how do those compare in terms of outcomes to resective surgery?
So the main advantage of these methods is that they're not as invasive, and you don't remove as much brain tissue. So they're more focused, which means there's less complication, less risk of having deficits resulting from surgery itself. But we need more data to find out if they're as good as resective surgery, because one might argue that doing surgery and removing brain tissue might be more efficient in terms of getting rid of a complex epileptogenic network than just interrupting it with more focused ablation. So I think they're great for certain indications and for small and well-localized lesions, but I don't think they will replace resective surgery.
Okay. And one other thing we hadn't talked about is the deep brain stimulation, which is not yet FDA approved for epilepsy. I believe it's approved for Parkinson's. But is there any way, can you talk a little bit about that and why it was not FDA approved, and then whether there's any way for patients to access that treatment?
So deep brain stimulation, I think that there's still possibility that it might be approved, but the FDA denied it, I think last year or a couple of years ago. It is approved in Europe, and the most common method of deep brain stimulation is stimulating the anterior thalamus. Is it possible to convince the FDA to revise, look again at the data from the clinical trial and consider, DBS for a subgroup of patients, or I think the requirements of the FDA were not met. They were not satisfied with the numbers, but it might be difficult to do a similar study again with multiple centers involved, but I'm not up to date on whether there's still discussion in terms of revising more detailed results from the clinical trial. As far as I know, currently there are no centers doing any DBS trials, so I don't think there's a way for a patient to get access to this treatment in the U.S., but possibly in Europe.
Okay. And what do we know about the effectiveness and safety of transcranial direct current stimulation and then transcranial magnetic stimulation in patients with epilepsy? And is there any way to access that? I think I looked recently and I didn't see any clinical trials being done, but I know this has been there's been some research done on it.
So these are actually interesting and probably promising treatments. Transcranial magnetic stimulation involves using magnetic fields to trigger electric discharges in certain parts of the brain. It has actually been approved by the FDA for treatment of depression. It was evaluated. There were multiple small studies evaluating this method in treatment of epilepsy, and they did show encouraging results. And there are different applications. It's used in epilepsy for investigation of cortical excitability. So use stimulation, then you measure different thresholds to see if brain tissue is excitable and the degree of that excitability. then using that, you can actually benefit from magnetic stimulation to find out if seizure medications are effective or not. And then you can also use magnetic stimulation to maybe reduce the frequency of seizures. We still need more trials, larger trials, to really know whether this will have a lot of practical application in terms of epilepsy treatment. But the initial results from small trials are encouraging. I thought there was probably a small clinical trial going on at Harvard, and maybe I will have to look at clinicaltrials.gov. That's always useful to search that website to see if there is anything going on.
But I think I probably just looked in Michigan. That's why I didn't see it. Okay.
I don't think there's any place in Michigan offering this treatment or doing research on it. And then transcranial direct current stimulation is in very early research phases, but there were a few small papers, small trials, and they did show potentially good results. But I do think that usually groups that are interested in transcranial magnetic stimulation also consider direct current stimulation. So I'm thinking also probably a group in Harvard is doing trials on that as well. I would refer listeners to clinicaltrials.gov, and it's a very good website, and you can just use the search field for magnetic stimulation and see what's going on right now.
Okay, and so these are some things that we've had some trials of, or they've actually been FDA approved, but there's some other things on the horizon that we're quite a bit farther away from. Can you talk about some of these possible surgical procedures on the horizon, things like optogenetics and focal cooling devices and other things?
So optogenetics, actually, this is a fascinating method that is currently under research. This is based on light-sensitive proteins. These are proteins that are activated and they exert certain functions. They're activated by certain wavelengths of light. So you can basically transfer genes into brain tissue, usually through viral vectors, through viruses, and use these genes to allow expression of the proteins that are light sensitive. So basically integrate them into the brain tissue and then use light stimulation to activate them for different functions, either decreasing excitation in brain cells or increasing inhibition or activating neurotrophic factors that promote survival or repair of neurons. So it's really fascinating. It is speculated that the light therapy could be delivered through optic fibers and maybe through a device similar to RNS, to NeuroPace, where you basically detect a seizure discharge and then deliver light stimulation to activate these proteins and try to abort the seizure. That's all very theoretical. I think it was tested on mice. I don't think it has even been tested on mammals. So we're far from seeing this realized. But it's really fascinating and potentially can be a treatment in the future. You mentioned, Russ, cooling devices, is that right?
Yeah.
So same idea. I mean, the cooling device would target the trigger zone for seizures and induce hypothermia. And we already have data saying that cooling of brain tissue can decrease seizures if it's applied to certain areas. And we know from physiology that low temperature has effects on cell physiology, including decreased excitation. Again, this is far from being realized. The technical details of having what kind of delivery can we use to basically cool a part of the brain. There are a lot of details to be worked out, but again, in theory, it's very promising.
Another thing that I've read a little bit about, again, very theoretical, is focused ultrasound, either to accomplish the same sort of thing that laser ablation would accomplish, or it could also potentially be used for more neuromodulation, more like stimulation-based therapies.
Right. And this is also in the research phase, and I think before it was considered for epilepsy, there was some research on using focal ultrasound therapy for essential tremor and also for neuropathic pain. But it's getting more attention in the epilepsy research community. So in this method, you basically deliver high doses of ultrasound energy to a certain part of the brain, for example, an epileptogenic lesion. And I think there's some research going on right now. It's supported by the Epilepsy Foundation. In theory, you might be able to ablate targets responsible for generation of seizures. For example, hematoma again, or mesial temporal sclerosis. But there are a lot of technical details that still need to be worked out. One potential problem when using ultrasound energy is that you can cause collateral heating, so you can cause heating of the skull base, and that might be a complication, and finding a way around that would be important for research to be applied clinically.
Okay. And again, another similar sort of approach would be having some sort of focal medication delivery system, like a pump or something that would be either responsive or would be continuous and would deliver small amounts of medication to a particular region of the brain or area of the brain. What do we know about that so far? Is that?
And this is also a fascinating idea. So the idea is to get the medication to the part of the brain that needs it without causing, side effects and without exposing the whole body to the medication, and also to get the medication there very quickly. So, one can imagine a combination of a seizure detection device similar to RNS that can also deliver medication when needed, when it detects a seizure discharge. I think it's being investigated in animals, but it will be a while before it reaches a stage where we can try it on humans.
Okay. And are there any other promising techniques or devices out there that you've heard of that I haven't mentioned?
Can't think of anything. Well, one actually talking about neuromodulation or neurostimulation. There has been research on stimulation of the trigeminal nerve, another cranial nerve. So we know about the vagal nerve stimulator, and trigeminal nerve is another cranial nerve, and there was some studies actually using external stimulation of trigeminal nerve, but the results were not great. It doesn't mean that the therapy is not promising, because when you're researching neuromodulation, there is a lot of room to try different settings and different strengths of stimulation. So I think we'll be seeing more research on that.
Okay. So a lot of these therapies, including the currently available RNS, involve the use of seizure prediction technologies. How important is this to the effectiveness of these therapies, and are we seeing significant progress in terms of the accuracy of this technology?
I think there will be more and more research about seizure prediction, and I think we'll be seeing more devices that are similar to RNS, and we'll see also improvement in terms of accuracy of seizure detection. So in terms of the importance of seizure prediction for the success of treatment, I mean, it's very important to detect the seizure. If you're trying to stimulate and abort it, it's very important to detect it in its very early stages. I mean, of course, the longer you wait, the more the seizure is spread, the more difficult it is to abort it and stop it. So it's essential when you're using neuromodulation with targeted treatment against the trigger zone to detect the seizure as early as possible. But I think we'll be seeing more in terms of seizure detection techniques. There is a recent study on a device, an implanted device that can predict seizures, and this can provide, patients with, might empower patients so they feel they're able to predict their seizures and stay safe, might improve their quality of life. It might also allow for other interventions, not necessarily, stimulation, electric stimulation of the trigger zone using something like RNS. But if for example, you're able to predict that the patient is going to have a seizure soon, is it possible to take a medicine or an injection of some sort? So there might be a lot of different applications for seizure detection techniques, and I think we will be seeing a lot more of that soon.
That's a good point. Yeah, the treatment wouldn't necessarily have to be automatically delivered. It could be delivered by the patient themselves. So that makes a lot of sense.
Right. I think there are a lot of different applications. So it's it might just be information that is useful for the patient. Help them stay safe, help them plan their day. Help them know when to take medicine, additional medicine for extra protection. And in the future, it will be used for the other, interesting techniques we talked about, like local drug delivery systems and cooling devices.
Okay. What about stem cell-based therapies, things like turning skin cells into stem cells and then into neurons, and then testing the response of those cells to different medications so that people can essentially avoid having to try 20 different medications and start with the one that's most likely to be successful with their particular neurons. What have you heard about that, and what research is taking place in that area?
There is research, and again, I think it will be a good while before we see this realized. So neurons and the supporting cells, the glial cells, they can be generated from stem cells. So you can implant them basically and have the cells derived from stem cells incorporate into the brain tissue, and they can integrate into an existing network of neurons, and you can use them to yield different functional results in terms of inhibition or decreased excitation, or again trophic support to promote repair of neurons. And you can, as you said, you can use it in gene therapy. So you basically generate cells from stem cells that have specific functions, or you basically have cells that are capable of releasing therapeutic compounds, or have different mechanisms in terms of regulation of neurotransmitters to decrease excitability. It's still, far from being realized, but again, very promising.
And this wouldn't involve embryonic stem cells, because I know for some people that's a controversial issue, but this is involving. Can you explain what types of stem cells it would involve?
Well, for example, you can skin cells, for example, but it might involve embryonic. I mean, I think a lot of research is on using cells derived from embryonic stem cells.
Okay, great. Are there any other therapies on the horizon worth mentioning that we haven't discussed yet? It seems like we've covered most of what I'm aware of. Are there anything else that you'd want to mention?
I can't think of anything else. Actually, Russ, you were very thorough.
Okay, great. Well, then let's open it up for questions. Okay, so who has a question? Who wants to get us started?
Yes, I have a question, Kathy Love.
Okay.
You mentioned 3 medications, Dr. Haykal, and I couldn't catch the first one. Would you please go back and just tell me the name of that again early on?
The first one I talked about was ezogabine. The brand name for that is Potiga, Potiga.
Okay, very good. Thank you.
No problem. Thank you.
Could you mention the brand names for the other 2 drugs that you spoke about, the latest?
Oh, sure, yeah. So the first one was ezogabine, which is Potiga.
Mm-hmm.
The second one is perampanel, which is Fycompa. It's Fycompa. And then the third one is eslicarbazepine, which is Aptiom, Aptiom.
Thank you.
Thank you.
I believe there was also a new one just released, an extended release of Topamax.
Correct. That's, I think, Trokendi is the brand name. Right. And there's also an extended release version of oxcarbazepine, and this is called Oxtellar XR. So that's the extended release version of Trileptal.
Uh-huh.
These are 2 new medications. I think they came out in the past year.
Yeah, and I think there are some more extended release ones coming out very, very soon as well. So, other questions?
Hello, I don't know, am I on?
Yep.
Okay, I have a question related to the ketogenic diet. I understand that they don't really know the mechanism of why ketosis has an anticonvulsant effect, but I know in terms of athletes, there is some investigation, or there are certain products, I believe, out there that have allowed athletes to be put into a state of ketosis in terms of athletic performance without following a ketogenic diet. Are you aware of any research or drugs looking at possibly allowing a patient to take some type of a drug that would put the body in ketosis that would simulate a ketogenic diet without actually needing to follow that diet?
I know the idea was considered. I'm not aware of research, going on, or a specific compound being investigated. I'm just aware of it. That doesn't mean it doesn't exist, though.
Okay, thank you.
Thank you.
Other questions?
Can I ask you a question, please?
Go ahead.
I thought you mentioned light therapy of some sorts, and I'm not real familiar with that, but there's also a photosensitive epilepsy where there's a lot of different triggers from TVs and computers and things along that line. Can you explain the difference of why that might be effective?
So we're talking about light therapy on a cellular level, molecular level. So basically, exposing proteins in brain cells to light to activate proteins with specific function. Actually, proteins we can, basically modify ourselves and implant within a brain cell network. So we're talking about exposing those proteins to light to activate them. That has nothing to do with photosensitive seizures. Photosensitive seizures happen because of a reflex mechanism where a visual cortex being activated by light would contribute to seizure starting. But light therapy we're talking about is using certain wavelengths of light to activate cells. If we're imagining an implantable device that uses light therapy, it would be, exposing brain cells inside the skull to light. But of course, that's still an idea, and it's very far from being realized.
Right. Yeah. So there would be, but theoretically, fiber optic, fibers inside the skull that would be activating these cells, as opposed to something that you would be visually seeing yourself. So.
All right. Yeah. Did I answer your question?
Yes, sir. Thank you.
Thank you.
Okay. Other questions?
I have a question. This doesn't really relate to new or recent advances in epilepsy, but it's just more of a general question for an epileptologist.
That's fine. We've got
Sure.
plenty of time left, so we can broaden the scope of the questions if we want. So.
Okay. So I've read and I understand that the prevalence or the incidence of epilepsy is that 1 in 26 people at some point in their lifetime will be diagnosed with epilepsy. Is the prevalence of epilepsy on the rise, like we see with autism and some of these other neurological disorders? And if so, why do you surmise that this is the case?
I think there is an increase in epilepsy in older population, and that might have something to do with baby boomers too. So the population subgroup with increase in epilepsy incidence currently is the elderly. We're seeing a rise in diagnosis of seizures and epilepsy in elderly people.
Okay, but not so much in young pediatrics in that population?
I'm not aware of increase, no. I don't think the incidence or the prevalence is increasing in children compared to what we already know.
Okay, thank you.
Thank you.
I will say that our data, at least in the U.S., on the prevalence and incidence of epilepsy is very poor because we don't have any kind of registry. We don't have a national healthcare system where we can, get data from the entire population. So that perhaps looking at other places like in Europe or other places that have national health care systems, they might have better data and might be able to find any trends in terms of prevalence and incidence, but I'm not aware of any as well.
Yeah, that is correct, and I think it's the reason that a lot of our demographic data on epilepsy comes from Europe, actually.
Right.
Thank you.
Okay.
Thank you.
I have a question. Since we're broadening this a little bit, I would like to understand how an MEG or MEG tests work when, like a long-term inpatient study, EEG study doesn't show where turns out to be normal, and yet a patient is having a lot of simple partial seizures. Can you explain how one wouldn't work, but just what is an MEG test? That would be very helpful to understand that. Thank you.
So your question is whether an MEG test would detect abnormalities in a patient who had a normal long-term EEG, is that correct?
Yes. Just basically, even what is an MEG test? I have to go for one, and I don't even understand completely what it is, and because nothing showed up on my long-term inpatient test, and so I'd like to even understand
Sure.
how something might show up, because I don't know what it is.
So basically, MEG stands for magnetoencephalogram. So EEG is electroencephalogram, and MEG is magnetoencephalogram. So basically, the electric activity, the electric discharges that we see that occur in the brain and are indication of potential risk for seizures in a given part of the brain. We can detect those with EEG, right? EEG measures electric activity in the brain. If you remember from physics, electric discharges would also have magnetic fields. So a magnetoencephalogram, the MEG, would basically measure those discharges but would detect the magnetic field they generate. So it's basically looking at those, most often the way we use MEG is look for sharp waves, or the spikes is what we call them on EEG. These are, if you think of a seizure as a fire, then sometimes we see sparks that indicate potential for seizures. And the MEG can record these with much higher spatial resolution compared to EEG, and can localize them much better. So you can see where these spikes are coming from, and then you can superimpose that on MRI and have very good localization of where they're coming from.
Oh, okay.
And especially sometimes also spikes on EEG or electric abnormalities that we see on EEG might be in a part of the brain that causes them to have a very wide field on EEG. So what means when we look at the EEG, we cannot tell exactly where they're coming from, and then MEG can be really helpful in that regard.
Okay, so,
it can also detect ones that the EEG was not capable of detecting, so it can detect the magnetic field of these discharges, especially if they're coming from deeper structures in the brain, and they're structures that are not close to the surface.
So would it be less important that you have a seizure while you're having a MEG?
It's a very good question. When we do MEG, we're usually looking at the activity in between seizures, not seizures themselves. It's usually a few-hour study. We don't know enough. We don't have enough data. Some patients do have seizures while they're getting their MEG, but because this is not a very common occurrence, so the answer is we don't know. Probably it will be helpful, and maybe this is something we will be looking at in the future.
Okay.
But usually when we do a MEG study, it's looking at the activity in between seizures, not trying to record seizures.
Okay, thank you. Thank you so much.
Thank you.
I have a question related to that. How available is MEG in the state of Michigan, and how important is it to have, I mean, are there different, like with MRI machines, there's different levels or different powers. Is the same thing true for MEG? Are there higher quality machines, and does that have a big influence on how likely it is to detect?
I would say the bigger influence would be the skill of the person interpreting the results. I think that's much more important. And in the state of Michigan, I think the only MEG machine that is available is at Henry Ford in Detroit. We're also, I mean, Grand Rapids, we're close to Chicago, so there's one at the University of Chicago as well, and we refer our patients if they need a MEG, either to Detroit or Chicago.
Okay, that's great to know. Thanks. Other questions?
I have a question. I suffer from tonic-clonic seizures only at night. Have there been any drugs that have been, I guess, in general, more effective for those?
For seizures that happen at night?
Yes.
Or for tonic-clonic seizures?
Tonic-clonics at night, I guess. Because
I don't think that.
When I start to feel them coming on, I can, if I can wake up early enough and kind of walk around, usually I can have them, I guess, go away. And I didn't know if there was anything special about those kind of seizures that made other drugs maybe more effective than others.
I don't think there are medications that work better against seizures that occur at night or during sleep specifically. I don't think we have a medicine that works specifically for these seizures now.
Are there approaches in terms of dosing, though, that might be more effective for nocturnal seizures?
A very good question. And sometimes we try, and in some patients this might be effective. Having, if a medication is dosed twice daily, having giving a larger dose at night, so there's basically a higher peak during sleep, or in some cases using benzodiazepines also at bedtime to try to prevent seizures during sleep.
I have a question.
Also, just to follow up, it seems like that would also be another real benefit of having good seizure prediction technology and that sort of responsive thing where it could identify that a seizure was occurring and deliver treatment even while you were sleeping. So go ahead.
Correct. Very good point.
You had a question?
Exactly. If I had something that I had something that just might be an alarm that went off, I mean, that would probably prevent most all of my seizures just by waking up.
Right.
So I mentioned when we talked about seizure prediction devices, there was a trial. I think they tried that device on 15 patients where they implanted electrodes in the brain, and this is connected to a device, and they developed certain algorithms to detect seizure discharges, and then they would give a patient a warning, and I think they had 3 different levels of risk in terms of whether a seizure is going to happen or not. It still needs, of course, this is a very new idea, and it still needs a lot of development in terms of accuracy, but I think this is something that might be realized pretty soon.
I have a concern. I don't know if it's a seizure or not. A year ago, my house was broken into. I was beaten and left to die. So since May the 23rd up until now, it's like I'm fighting myself at least 2 or 3 times a week. I butt my head upside the headboard, the footboard. I wake up the next morning, I'm bruised, I'm sore, as if someone had physically beaten me, but I'm fighting myself in my sleep. It's like, I don't know what it is. I know I'm frightened. I'm reliving the trauma.
Okay. Do you dream at the same time?
No, I go to sleep. I'm calm. I wake up, and I'm going through this episode.
Okay. Well, that certainly might be concerning for a seizure, and I advise you to see a doctor about it. And there needs to be investigation of different possibilities.
Mm-hmm.
There's also
don't lay but a little while, but it's scary.
There's also the possibility of psychogenic non-epileptic seizures, which can be very similar to epileptic seizures, but they're often caused by psychological trauma, and having been through what you went through, that could be something that's going on as well. So I'd ask about that as well.
Correct.
Okay. Other questions? Okay. I have a question related to similar to the seizure prediction technology, but this is more in terms of alerting people to a seizure that's already begun. There are a number of devices. There are movement-based devices that you put under your mattress. There are devices that there's a smartwatch which you wear, and it also detects movement and can alert a cell phone, which then can contact whoever you program it to contact to let them know that you're having a seizure. Can you talk about these different devices and the potential value of them, and also the limitations of them?
I think the main limitation is anything that is movement-based will have a lot of false positive alarms. And patients ask about them. Honestly, I don't know about all the different devices that are available commercially, but we know that this is a problem. I have a few patients who tried some of them and they were not satisfied. So the idea makes sense, but I think I don't think that the accuracy is where we want it to be.
Okay. We've got about 10 minutes left, so if anyone has any questions, now's the time to ask them. So, anyone else?
I have a question about meds. Are some medications better for simple partial and complex partial seizures, and others better for tonic-clonic?
Well, definitely. When we choose a medicine, it mainly depends on the type of epilepsy. So certain medications might be good for idiopathic generalized epilepsy, and others might be good for partial epilepsy. And sometimes if you choose the wrong medication, you might make things worse. For example, using trileptal or carbazepine to treat idiopathic generalized epilepsy, or a person with absence seizures might make them worse. So there are medicines that are whose spectrum of effect only covers partial seizures, and others that have a broad spectrum. And we know that some medications work better for myoclonic seizures, for example, levetiracetam or Keppra, and valproic acid or Depakote. And they work also very well for primary generalized tonic-clonic seizures. These are ones that start all over or start on both sides of the brain at the same time, not in a spot of the brain and before they spread. So the answer is yes. There are some medicines that work better for one epilepsy type, but not the other.
Okay. And then how, many different meds do you try on a person before you just say, okay, this is intractable, we're going to, I don't know whether, maybe that's just more a question I asked my doctor, I'm not sure.
No, this is a very good question. The definition of drug-resistant epilepsy or refractory epilepsy or intractable epilepsy is failure to respond to two medications at therapeutic doses, at good doses, that the patients tolerate. So it means if you tried a good dose of one medicine and you were able to reach the maximum, and then you tried another medicine and you were able to reach the maximum, so you tolerated the medicine and you took a good dose of that medicine and continued to have seizures, then your chances of becoming completely seizure-free become really low after that. And definition, the criteria for drug-resistant epilepsy would be met at this point, and it would be time to consider different treatments. It doesn't mean we stop trying with medicines, because again, we spoke about this a few minutes ago. Occasionally we might achieve success, we might be able to achieve seizure freedom with additional medicines, but at this point, after failure of two medicines, it would be time to consider other treatments, possibly surgery, possibly a neurostimulation device like VNS or RNS.
I think that's another reason why it's important to, if you're seeing a general neurologist, and you've failed two medications, then to go really to the next level of care, which is seeing an epileptologist, because that's when you can really learn about other possible treatment options. The epileptologist can also evaluate whether the first two medications that were tried were even appropriate or not, too. So.
Oh yes, that's very true.
Okay. Other questions?
Yeah.
I have a question related to refractory epilepsy and cognitive function. Is there evidence to support that if someone has refractory epilepsy that they do have a persistent decline in cognitive function? Has that been studied? And I guess the question would be, if it is refractory, there's probably nothing that could be done to halt that cognitive decline. But I'm just curious if that is something that is seen or if it's very individualized.
Yeah, this is definitely something that we see, and is something that is well established and studied. So, cognitive dysfunction in epilepsy can happen because of different factors, including the epilepsy itself, or the lesion that is causing the epilepsy, and also sometimes because of treatments and being on multiple medications in refractory epilepsy. Some medications might have a negative effect on cognition as well. But we know, for example, in temporal lobe epilepsy, and temporal lobes is where a lot of our memory function resides. If you're having a lot of seizures or if you have mesiotemporal sclerosis, then this will have an impact on memory and cognition, on verbal memory, verbal abilities. If it's on the left side, visual memory if it's the right side. So yeah, seizures can, especially seizures that are not well controlled, can have a negative impact on cognition.
And then, kind of in follow-up to that, is there, I know there's the subjective interpretation by the patient that they feel the decline in cognitive function. Is there any role for, like, periodic neuropsychological testing, or no?
If the patient is reporting worsening, I think it's reasonable to investigate that further. We don't do it on a routine basis. Not everybody will have, of course, not everybody with epilepsy will have cognitive decline or cognitive dysfunction. But if there are complaints of cognitive dysfunction, we often recommend further evaluation, detailed evaluation through a neuropsychological battery.
Thank you.
And in terms of research, is there any research? Because on our needs assessment that we did, I know memory problems were listed as having a greater impact on quality of life than seizures themselves. So, yet it seems like there's maybe not quite as much emphasis on looking at that and how to prevent that decline. Are you aware of any research that's being done in terms of possible ways to intervene to halt or slow that decline?
I think that would be research on epileptogenesis. Right. Again, the decline can be caused by either the seizures themselves. The more frequent seizures you have, the more likelihood you will have further dysfunction or worsening, and also the epileptogenic process itself and what's going on in that brain tissue that is generating seizures as well. So I think to prevent this would probably mean coming up with a medication that affects epileptogenesis and therefore affects the long-term outlook.
And what about hippocampal sclerosis? Because the hippocampus is involved so much in memory and mood as well. There's probably a role of hippocampal sclerosis. But do we know really, it's kind of a chicken-egg thing, is that something that is caused by repeated seizures, or is it part of the process, the underlying epileptogenesis? Do we know much about what causes hippocampal sclerosis?
We don't know what exactly causes it. We know that certain factors can lead to development of hippocampal sclerosis. But as you said, there's a lot of controversy on what is the chicken, what is the egg. For example, febrile seizures in childhood are associated with are considered a risk factor for developing hippocampal sclerosis later in life, especially if they're severe and long. But there's controversy in is this really a chicken or the egg? But we know hippocampal sclerosis, memory impairment is definitely a feature of hippocampal sclerosis, and I don't think the seizures themselves only can explain that what's going on in the hippocampus in terms of dysfunction and cell damage, if you may. So having more seizures worsens things, though, and we know about kindling, and we know about having uncontrolled seizures does make things worse in the long term. So achieving seizure control is important, but it's also not everything. And this is again why we need the medication that works against epileptogenesis.
Right. Okay, we have time for one more question. Go ahead.
I have a question, and it's pretty much a little bit different. My uncle just fell off a ladder a couple of days ago, and now he's having seizures, but they're calling them strokes. And they don't know, my cousins and I don't know what to do.
But did he see a neurologist? Was he seen at the hospital?
He was airlifted to Ohio from Michigan. They did MRIs. They've done all the tests. One neurologist is saying it's not seizures, and the heart doctor is saying it's seizures.
Okay, well, usually when it's not clear and the history does not give us all the information we need, what we recommend doing is continuous EEG monitoring. So that would be admission to the epilepsy monitoring unit with continuous EEG with a video camera in the room to try to record these episodes, and that should provide an answer on whether they're seizures or not. If they're seizures, they would cause changes on the EEG. We would detect the electric discharge with EEG electrodes.
Yeah, because you were talking about older people, and he just turned 75.
Yeah, it's definitely much more difficult to diagnose seizures or epilepsy based on just description of symptoms in older adults, because there are so many things that can be confused, like TIAs or mini strokes and dementia and other things. So that is more of a challenge, and that's why, like Dr. Haykal said, going to an epilepsy monitoring unit is really the best thing to do. Okay. Well, we are at the end of our session, and I want to thank you so much, Dr. Haykal, for your time and your expertise. And I learned a lot, and I'm sure everyone else did.
Thank you, Doctor.
Yeah. So.
Thank you, everyone. Thank you, Ross. It's a great opportunity. I appreciate it.
Thank you.
Thank you, Ross.
It was very good. Thank you.
Bye.